Our next speaker is Dr. Phil Katz, and he's going to talk to us about when medical therapy fails and why. Phil?
Thank you, Blair, Peter, Dr. Schnoll, and the AFS for giving me the opportunity to give this talk and be part of this very interesting and evolving group. You see the title. I will stick to task. As I've already invested 20, now I still got a full 15, look at that. I will not talk about how to work people up, and I will not talk about how to treat people. I will talk about failure, and we'll stick directly to why. I have nothing to declare, disclose, or otherwise. If I did, I don't know, maybe I'd be happy about it, but I don't. So, what are the definitions that we're working with today? There are two. You heard a little bit about both of these scenarios from Dr. Yadlapati, but scenario one is that you have an objective diagnosis of GERD, documented by erosive esophagitis and or abnormal acid exposure on a prolonged pH monitoring study, but unpleasant symptoms remain despite a PPI. And scenario two is a patient with symptoms suspected due to GERD who's been treated empirically, but the symptoms have not been relieved to their satisfaction. Now, which scenario dominates is in part dependent on your practice, but I would venture to say that you should be thinking about the same question or questions. And the ultimate question that must be answered in these patients is really the same. Are the symptoms in front of you due to GERD or due to reflux? And if so, why? Because with that information, you can make a decision about prospective treatment interventions. Now, Peter talked about this quite elegantly in his talk, the genesis of a symptom. Raina alluded to it in one slide, but I think it's important to understand what determines symptoms as you think about why we can't relieve them or why we don't relieve them with medical therapy. The refluxate is mixed, and although acid is the major injurious agent, weakly acidic or non-acidic reflux causes symptoms. We may argue about what to do with it, but it causes symptoms. And bile is involved in the genesis of injury, and we could debate for years, and I know we have, on its role in reflux, but it's part of the equation potentially. The timing of reflux has been addressed in a couple of talks. Is it postprandial, is it upright, or is it nocturnal? And perhaps all of those patients will respond subtly differently to medical and surgical interventions. The severity of mucosal disease may make a difference. Esophageal clearance, if it is abnormal. Whether you are a volume refluxer, this being likely the genesis of regurgitation, or there's probably some component of hypersensitivity in those patients. And then anatomic and physiologic issues that Peter talked about in great detail, TLESRs, a so-called defective or abnormal lower esophageal sphincter, and the anatomical presence of a hiatal hernia. And then to be talked about tomorrow, gastric factors of accommodation and emptying. And then saliva, and the very, very ubiquitous issue of esophageal sensitivity to acid or volume, an evolving area, one that has to be very carefully worked out to determine the genesis of that sensitivity. And then remember, as clinicians, any other functional syndrome unrelated to the esophagus, like irritable bowel or migraine headaches, fibromyalgia, or the like, will impact on symptoms. And there's ample information and probably reasonable data to show that if you have a patient with any of those functional diseases, that their GERD therapy will be impacted by it, and certainly their response to medical therapy. So, an abnormality or alteration in any of these features could be responsible in all or in part for the failure of medical therapy, or perhaps GERD's not the cause of the residual symptoms. There's another problem. Joel talked about overlap between EOE and GERD, ruminators, aerophagics, gastroparetics. And then finally, the residual symptoms are functional, and those whys need to be dissected. Now, Peter was kind enough to let me use this slide in a way that I hope fits into this talk. As you know, PPIs are better for some symptoms and better for some things than others. That's a key and important finding. I don't have a pointer, but in this slide, the first, the white line is placebo, therapeutic gain is the orange line, healing, big gain for PPIs over placebo. Heartburn relief in esophagitis, big gain. NERD, less of a gain, but still better than placebo. Regurgitation, not so good. Very important, been focused on a lot. Chest pain, if you have GERD, PPIs are terrific. If you don't have GERD, no reason to even give them. Those are part of the thinking, or that is part of the thinking that we need to be dealing with. It's no surprise, and everyone knows, that PPIs do not reduce regurgitation as well as surgery. This has been amply indicated and pointed out in the preliminary results at 6 months of a randomized trial that Reg Bell is the first author of, comparing magnetic sphincter augmentation to double-dose PPI in patients with continued regurgitation despite being on a proton pump inhibitor. The MSA group is on the left, the BID PPI group is on the right. Basically, it's very clear that there's blue, no regurgitation in the MSA group, very few with no regurgitation or even mild regurgitation in the PPI group. So the symptom matters, particularly if it's regurg. Remember that PPIs do not always normalize esophageal acid control, and in some ways it's dose-related. These are past data from the Cleveland Clinic group. I believe, Joel, you were still around then, with Charbel and Michael Vasey, a retrospective study looking at once-daily PPI and twice-daily PPI, and the percentage on the y-axis of abnormal pH studies. Once-a-day PPI, expect 31%, 30% still will have abnormal acid exposure. So why would once-a-day PPI always work? Twice a day, fewer, but nevertheless a small minority of people with typical symptoms who will still have abnormal acid exposure despite BID. So the why may be the drug is either not enough or it's just not completely doing its job. And remember also that PPIs may not substantially reduce reflux episode. Again, a retrospective study from Don Castell's group looking at impedance pH data, looking at the total number of reflux episodes per hour on the y-axis. Patients who were monitored on a PPI, left-hand set of bars, monitoring off of PPI on the right-hand set of bars. Black is acid reflux. The empty box or white is non-acid reflux. So on a PPI, 24-hour, 2-hour postprandial, off of PPI, basically identical. Total monitoring on a PPI, slightly less, but not completely abolished. And remember, both remain, non-acid and acid on a PPI. Now, non-acid reflux episodes will cause symptoms. If you ignore that completely, I believe you do so at your peril. This is Marcelo Vella's paper from Gastro in 2001, one of the earliest impedance pH studies that showed that there was still postprandial reflux and that it was predominantly weakly, or what we called non-acidic back then. In this case, you see A and NA. Those are symptoms across the board: heartburn, acid taste, and regurgitation. All of the symptoms are produced by either acid or non-acid reflux. So one of the reasons that medical therapy may fail is that you have non-acid reflux causing the symptoms. Dose timing relative to a meal makes a difference in efficacy and intragastric pH. With meal on the left, without meal on the right, the time the intragastric pH is improved if you take your PPI before a meal. And quite frankly, very few patients who claim to have failed PPIs actually do that. An old study that shows that patients who have failed BID PPI are often taking their PPIs as needed after meals at bedtime or greater than 60 minutes before a meal. In that situation, you will have suboptimal efficacy. One study which shows that optimizing the PPI might actually matter from DD&S early this year, 64 patients with continued heartburn on BID Omeprazole, not taking it optimally by history, randomized to optimal dosing or continued as they were doing a significant decrease in frequency and severity of symptoms on the optimal regimen. Small study, not perfect in any way, but suggesting that, again, think about compliance and optimization. The time of the day that you're taking a PPI may make a difference in acid control. Intragastric pH on the y-axis, taking before breakfast, before dinner, or splitting the dose 20 and 20, difference in the amount of intragastric pH control being best with the BID doses. So once a day dose, inferior in the stomach, already shown to be inferior to twice a day in the esophagus. Keep that in mind. I don't know why this is stuck. So the pharmacodynamic response to PPI is variable and may be different depending on the PPI. A study we did in early 2000, Lanzo twice a day versus Omeprazole twice a day, what happens in the stomach, 20 subjects, all normals, not too hard to see. There are 20 different dots, and if you look and follow from lansoprazole to omeprazole, you don't always see the same intragastric pH response from drug to drug. So there's variability in what happens in the stomach. Ultimately, that could affect the esophagus. Now, there is a relationship between reflux at night and motility abnormalities. Again, a study that we published in APT in 2001, looking at the frequency of esophageal acid exposure during nocturnal gastric acid breakthrough in patients with varying degrees of GERD. Non-refluxers at night and refluxers at night are the two bars. The refluxers at night were 8 times more likely to have ineffective esophageal motility. And then looking at lower esophageal sphincter pressure in that group, again, a low sphincter pressure and poor clearance had an effect on your nighttime reflux and esophageal acid exposure. So motility clearly matters. The function of the lower esophageal sphincter really has something to do with medical failure. Now, this interesting study from the Chicago group looked at esophageal acid exposure in scleroderma patients who had continued symptoms despite being on high-dose PPI and compared them to a matched group of controls. In this slide, the percentage of patients is on the y-axis. The percent esophageal acid exposure is on the x-axis, from normal to varying degrees of abnormal. And as you can see, going to the far right-hand side, the scleroderma patients had much higher acid exposure than the patients who are controls. That's not a surprise, but it was not due to total reflux events. What it seemed to be most associated with was abnormal esophageal body motility. So the black dots are the SSC patients, the lighter dots are the control patients. If you look at normal motility, most of the controls, absent contractility, ineffective motility, tend to dominate in the scleroderma patients, which again is no surprise. So motility affects esophageal acid exposure time and likely the production of a symptom. And then finally, many people just simply don't have GERD. This is a consecutive series of patients who were studied with impedance pH monitoring, manometry, and endoscopy after BID PPI did not adequately relieve their symptoms. You can see the pie chart here. A substantial number of them had GERD. When you broke them down into the cause of the residual symptoms, there were a fair number with functional heartburn and functional chest pain, a handful who had SAP positive normal acid exposure, and then 30% who ended up having functional heartburn. So, when medical therapy fails, consider the symptom in question, review compliance, optimize the drug, think about the pattern of symptoms, ask the question, is motility normal? I didn't talk about hernias, but is it present? Is it what you would call large? I don't know what that means, by the way. I'd like us to fix that and put a number to it. Is there a paraesophageal component? Is gastric emptying abnormal? And ultimately, ask yourself if the symptoms are due to GERD. Then you will have an adequate explanation for why medical failure has occurred, and you can make a choice of symptoms. I do thank you for your time and attention, Dr. Schnoll, for the invitation, and I look forward to questions. Thank you very much.